And now, to continue the conversation, I'd like to call on those in the trenches of the fight against the opioid epidemic. We'll find out what they are doing and learning about the breadth and depth of the crisis. How are they educating young people about the dangers of opioid addiction? And what challenges are they facing? Please join me in welcoming Clay Stamp, Executive Director of the Maryland Opioid Operational Command Center. The Command Center was established by Maryland Governor Larry Hogan to facilitate greater collaboration on the opioid crisis between state and local entities. Carolyn Marano, Assistant Commissioner of the New Jersey Department of Education, which serves 1.4 million students in more than 650 school districts. And Dr. Frances Jensen, Chair of the Department of Neurology at Perelman School of Medicine at the University of Pennsylvania. She's also the author of the New York Times bestseller, The Teenage Brain. And finally, Admiral James Winnefeld, co-founder and co-chair of Safe Project US, a national nonprofit working toward overcoming the epidemic of opioid addiction in the United States. Thank you. Please join me in welcoming our panelists, and Rachel Rubin, healthcare reporter at The Hill, will be leading this conversation. Rachel, over to you.
Thanks so much to all our panelists for being with us this morning. We have just under 30 minutes, so we'll just dive right in. Admiral, I wanted to start with you. You have a really powerful story, which you wrote about in the Atlantic. And I just want to share the subheadline of that story because I think it summarizes it really well. As an admiral, I helped run the most powerful military on earth, but I couldn't save my son from the scourge of opioid addiction. I was wondering if you could share your story with us.
Sure, and I'll try to be brief because I know you have a lot to get done this morning. Jonathan was a wonderful kid, grew up in a military family, had been in 5 school districts in 6 years at one point. Very creative, very bright, gifted baseball pitcher, but also suffered from a little bit of anxiety and depression. And he was misdiagnosed as having ADD and was given Adderall, which led him to sort of self-medicate at night to bring himself down from that buzz that he got from Adderall, with a little bit of alcohol starting in our family liquor cabinet. Moved into marijuana, to which he became addicted. Please don't let anybody tell you marijuana is not addictive. And then moved into other drugs. Had a few episodes, had a rough time during his senior year, lost a girlfriend, was not able to play baseball his senior year because his grades had suffered. And this took him into a spiral that amplified his sort of addictive tendencies. And he ended up having an event which caused us to put him into long inpatient treatment, 15 months. And he did extremely well. He really got to the right places. We saw his brain heal. He got his emergency medical technician qualification during that time. He had gotten into the University of Denver, and we decided that after 15 months, which is a pretty good long time to be in treatment, that it was time for him to go to college. He had, in the meantime, written a very powerful essay as an incoming freshman at the University of Denver, talking about his addiction and how during an ambulance ride in his EMT qualification period, he had performed CPR on a man undergoing a heroin overdose in a McDonald's bathroom, and how that caused him to want to dedicate his life to helping people who could not help themselves. And so we're reading this essay literally as he's about to enter University of Denver, not knowing that he had just relapsed. And it turns out that, longer story in there, but we lost him on the 4th day of his freshman year in college. It was obviously a tragedy that you do not want to experience as a family. It's left us with a constant background noise of sadness, but it also inspired us to carry on his work in trying to help other people in starting our nonprofit, SAFE, which is Stop the Addiction Fatality Epidemic. You can hear us at Safe Project US. But we've been building the machine as we've been flying it and working as hard as we can to try to prevent other families from going through what we experienced.
Thank you very much for sharing with us. Dr. Jensen, can you tell us a little bit about why adolescents are prone to addiction?
Yes, there is a lot of emerging neuroscience over the last decade and a half, especially more recently due to advanced imaging and human studies, showing that actually adolescents are more vulnerable, not less vulnerable to addiction. This comes because of their special neurobiology. They have unique strengths and weaknesses. The first thing is that they have more brain cells and more synapses where we connect our brain cells talk to each other, and you use those to learn. They can learn faster, harder, longer, stronger than the adult, which is an advantage. The problem is that addiction is simply a form of learning that our brain does in a different, very specific system. So therefore, they can get addicted harder, longer, stronger, faster than an adult as well. And this is something we need to talk about, and this is to all kinds of addictive substances and experiences. The second part is that our brain develops from the back to the front. It is not done until the mid to late 20s. Males are somewhat later than females on average. And the early connecting parts, which are in the back of the brain, connect before the frontal lobe, frontal lobe is used for impulse control, risk aversion, decision-making, judgment, empathy, all those good things, yet they don't have that fully connected for in-the-moment, split-second judgment, like I don't want to do that. Instead, they have a very well-connected limbic system, which is about here in their brains, which is all about peer pressure, emotionality, sexuality, risk, reward, and impulsivity, and novelty seeking. So they're running, we sometimes call them Ferraris with weak brakes, and that can be, it goes both ways, positive and negative, but this issue with addiction, I believe, is sort of a perfect storm. They can get addicted harder, longer, stronger, faster, yet they don't have a frontal lobe to talk back to them to say, bad idea, don't do that. And that's why I implore us in the society around adolescents to give them a frontal lobe assist, because we do have our frontal lobes attached.
Carolyn, you're seeing students every day. What sort of opioid prevention education are you seeing in different New Jersey schools? You've said that they each have different ways of kind of tackling the issue.
Right. So our challenge is that in our lane, in our realm, we're talking about school-age children from 3 to maybe 21. And in New Jersey, we have great resources and we have great curricula, but it is clear that individual districts are doing individual things, individual municipalities are doing the same thing. So what our governor has charged us to do is to work interdisciplinarily with other agencies, because we have the access to the kids. So I guess the thing that we're working on very hard to do is identifying the people in places who can deliver messages where they'll be heard, as young as preschool. And as old, obviously, as high school. But it is a challenge. We're committed to it. We want to sit at the table. We want to sit with the Attorney General's, office, and we want to be able to. We bring a vast amount of knowledge in terms of folks. The commissioner was a practitioner. He was in a school. I have the same kind of experience, as well as the teams that we're creating. So we just don't want to do just something for intellectual purposes. We really need to figure out a way to take that next step and to take everything that we have and to bring it to the kids and the families. It's not easy, but we're confident that we can identify those folks.
Dr. Jensen, what sort of messages do you find work and don't work through your research?
Well, I think there's two kinds of messaging. One is to the parents and to the education system to remind them that the brain is still kind of a work in progress at this age, and that we have to know that what happens to a brain in this stage sets the stage for later life and their tendencies long term. So the important thing is to share the science that we know that there's this increased susceptibility, but there's also, we call it plasticity, meaning the brain, the synapses can change to experience. That's why they can learn faster and also get addicted faster. But if you get to these kids as early as possible, and be aware and alert that there could be an addiction problem, the faster you get to it, you can use that same synaptic plasticity to help with rehabilitation and undoing of some of the circuits that have been formed. So I think sharing that there are unique opportunities for rehabilitation, but to keep our awareness out there, because the other thing that's happening in this age window is the onset of mental illness, which often goes hand in hand with substance abuse. There's a reason why depression, bipolar, schizophrenia, psychosis doesn't happen in childhood, that it comes on in this window, because you need to have just enough of your frontal lobe connected to be able to sort of really manifest these diseases. And sometimes it can be for the first time, and nobody's thinking about it. These are stigmatized disorders, so nobody's really got their antennae up, and often that can be a gateway to dealing with an anxiety problem, except with a substance, and then that process starts with an addiction, an addiction cascade. So I think making this science that we have available to us now, which is very reproducible, both in the preclinical and in human now, available to educators and parents is important. One last thing with children is telling the kids as they progress through adolescence and into early adulthood. This is not over. Your brain is not done even when you graduate college, by the way. So making them more aware. And I do believe when you have to, stories like yours are so poignant and terribly painful. But when you talk to these kids, you have to talk to them as giving them novel information. That's what they're excited about. That's what they are trying to understand, why they are the way they are. And you know, almost like a TED Talk to them every time you want to make a point is very, very effective. And sadly, stories like yours, I think, can help change the minds of kids that might think it's just fine to experiment.
Can I just underscore what Frances just said, and that there are really two things when I speak to a group of high school athletes or high school kids that must be done, and there's one that can't be done. The one that can't be done is the just don't start or just say no routine. That just does not appeal to them at all. But if you can give them a story that they can empathize with, which means a credible voice out there in your high school, somebody who's either been an addict or who has suffered, a family that has suffered. But the other thing is the element of just say no, that's just say K-N-O-W, because these kids really respond when you describe to them the physiology of what's going on in an addicted brain. They wake up and they sit and they're rapt when they're listening to this. And then when you top it by telling them that now, you don't have to be addicted to be killed by this stuff now, that fentanyl is finding its way into cocaine, it's finding its way into Xanax and even marijuana. Your first try could be your last try. That really gets their attention. So empathy and the science, you know, the education of what's really happening in their brains, that's a powerful message for them that they'll listen to.
And wanted to talk a little bit about what Maryland's doing and sort of centralizing how to tackle the opioid epidemic. So can you tell us a little bit about Maryland's methods, Clay?
Sure, Rachel. We recognize in Maryland and frankly nationally that this is a crisis. It's probably the worst crisis that we've seen. It's affecting just thousands of people. And our governor, Larry Hogan, recognizes that we also in this country have a mechanism to coordinate crisis. And so we are implementing the provisions of the National Response Framework around 3 areas, and that's at the state level, providing support for our local communities around expanding access to treatment and recovery services, to address enforcement issues, because we know that we can only stem the tide of drug trafficking organizations. We have that deadly fentanyl that's getting out on the streets. We have to slow that up. We have to hold physicians accountable for writing prescriptions properly. But we also recognize that people that have substance use disorder really need to be in treatment, not be arrested. But most importantly, we recognize that the only true way out of this is through changing a culture through prevention. That's why it's so important that we reach our youth and that we have programs to drive that long-term effort. So I often say that we can't arrest our way out of this, but I also say we can't treat our way out of this. We have to do both, but we can prevent our way out of that. So in Maryland, we have a coordinating body at the state level that breaks down stovepipes between state government. It creates a platform for community organizations to come in to develop objectives in those 3 areas to drive forward. And then we empower local coordinating bodies led by the health officers and the emergency managers to push efforts in communities. And we've been doing that for 13 months, and we're actually seeing great results when it comes to program development. Through safe stations, people that have just reached that place where they need help can go to any fire station in one of our counties, knock on the door, and we have crisis responders ready to come and get them into crisis. We have programs for our youth, regional art programs. We're implementing programs in our schools. So we're seeing programmatic success, but at the end of the day, the measure is going to be the number of people that are being affected, as in dying or having non-fatal overdoses. And right now what we're seeing is this crisis evolve from a prescriber-based crisis to an illicit drug crisis. So in the last 2 years, we've seen a 14% reduction in the number of prescriptions being written in Maryland, and a reduction in the number of fatalities related to prescribed opioids. What we're seeing now is 70% of the people that died last year was from illicit fentanyl. The street drugs have never been so dangerous. And we're seeing that deadly fentanyl that's flowing into our streets and poisoning people. We're seeing it in not only pure fentanyl, but in heroin. We're seeing it in cocaine with an older population that is narcotic naive. So it's a dangerous situation. But if we're true to the process, we believe in Maryland, a coordinated process, we will make we'll make headway. It's hard work. The key to this whole thing, and I can't overstate it, because 13 months in, I pinched myself saying, how can 64,000 Americans die and we're not at the top of the tallest building shouting from the tops of our lungs that we have to do something about that. And the answer is, this crisis divides us. It strikes us very deep, a deep fear inside of us. And there's a divided view of how to address this crisis. We have to overcome stigma through education. And so that's critical. Elevating the conversation, putting a face on it, helping people understand that people that have substance use disorder need treatment.
And that sort of brings up just kind of the awareness issue. And Roy, I know SAFE is looking at how to raise public youth awareness about this. Can you tell us a little bit about those efforts?
Sure, and I would underscore what Clay said about the stigma piece. We believe the awareness needs to be raised for two principal reasons. One is to get the resources dedicated. It's going to be expensive to solve this thing. Dedicated, which is going to require pressure on the political system and coordinated action at government, community, nonprofit level. And the other is to lower the stigma. The stigma is preventing so many people from achieving treatment or being willing to go into treatment. Imagine that you're a young woman who has an infant daughter who is addicted. You are addicted, and you know you need treatment. You want treatment, but you know that if you go into treatment, they're going to take your daughter from you. That is stigma that we've got to overcome through more than just yelling about it or saying, don't have stigma, it's just a disease. There are real things we need to do to help get rid of it, to help eliminate the stigma's impact on the epidemic. There's a place out in Denver right now that will take that woman in and will let her keep her daughter. And they'll give the daughter the right kind of care, but they're able to stay together in that treatment facility. So one example of a community that's trying to do something about this. But until we're tired of hearing ourselves talk about it publicly, through every possible social media venue, through a national advertising campaign with the right messages, not just a just don't start or just say no message, but a really thoughtful, bring Madison Avenue to bear on this thing, I think we're going to have a hard time getting it kickstarted. The country is beginning to understand there is an epidemic, but the wonderful citizens of this country are about an inch deep in understanding its complexity. And when you go after a solution 1 inch deep into a complex problem, it's really easy to lunge for solutions that don't work. So,
Dr. Jensen, did you want to jump in?
Yes, I think the other aspect of this is to make people aware that addiction is a sadly natural phenomenon of all our brains can become addicted. If you are given if you were held hostage and given repeated doses of heroin, you would be addicted within days, and you would be behaving in the same way with your brain is the only thing it wants is to get more of this substance because that circuit has been now reinforced and has been developed. Imagine that an adolescent, that can happen so much more quickly. And also know that there's now evidence that being addicted to one kind of drug actually increases your ability to become addicted to the next one because the circuit's sort of already formed and that behavior is already there. So we think about, cannabis addiction, for instance. Well, that is just cannabis, but cocaine addiction, all these things, alcohol addiction, there's evidence to show that cannabis, chronic daily cannabis use increases your addictability to alcohol, and there can be interactions like this. So we have to realize this is a thing all of our brains could do. All of our brains can become addicted, and that has to get out there to help destigmatize. It's a situational thing, and if it's also combined with mental illness, which affects 1 in 4 to 5 of our adolescents, and it's about 75% of people with major affective disorders have their onset between 16 and 26 years of age, we're talking about kind of this, again, this sort of perfect storm of all of these things happening in a society that can be in denial or just it's not on our radar and it's stigmatized. So this, I think the mental illness piece also kind of comes along with this because it often co-occurs.
yeah. And the stigma piece, if you think of what I believe are the 3 pathways into an opiate addiction, one is overprescription of opiate painkillers for either a medical or a dental procedure or an injury. Choice is an abstract concept in that pathway. Your doctor or dentist is telling you, take this drug for your pain. And I've done an informal survey over the last 3 months of anybody I know who's had one of these procedures done, and I've asked them, were you prescribed painkillers for your pain? And the answer is yes. And then I asked, did the doctor or dentist give you a verbal warning about the dangers of using this as a painkiller? And zero, literally zero of the people I've spoken to have said yes. In fact, many of them have come back and said, not only did they not give me a warning, they demanded that I take the prescription because of the fact that doctors are now evaluated on their ability to treat pain. So trying to tell somebody this is a mental or, ill or a failing or a moral failing when they became addicted because they broke their ankle is ridiculous in this country. And the other two pathways, self-medication for a mental anxiety or depression, and then the party path, even those, especially regarding the development of the adolescent brain, are abstract concepts in terms of choice. So we have to get rid of the stigma. It's something that the only way you do it is by educating our people about how this happens.
The other thing we're finding in Maryland, I mean, we can have the conversation about the symptom, which I would offer to you that the symptom is people that, are opioid addicted. But, I once heard a spiritual leader say one time, the human being can live days or weeks without food and water, but it cannot live 1 second without hope in something. And so we have a lot of individuals that have found themselves at the intersection of loss of hope and lack of purpose. And so we've started working with our business community and working with them to try to accept a little more risk and invest in their employees and create a structured process where people can operate in their businesses and also be in recovery. So that's critical that we be able to open opportunity for people as well to address that potential hopelessness.
Carolyn, did you want to jump in?
Yeah, I did. As we speak, I just want to say something about being able to reach folks of all different socioeconomics. I'm a product of urban education. I'm an urban educator, and we start to think about people who don't even know what a stigma is, because it is a way of life. And so I think it's important to at least say and to start to talk about how we come together to be able to reach the folks where, death and dying young is a very common experience. And so we have to make sure that the message that we're sending is heard, and all of this really important information is heard in a way that can make sense to them. In schools, we see children coming into preschool, into kindergarten, that have been born addicted. And when you start to talk about the overprescription of medication, suddenly they've got ADD. They don't have ADD, but the doctors are prescribing them medication for ADD, or they get classified as emotionally or behaviorally disturbed. All of this is part of what we have to look at and address. And they're big issues, but they're being tackled in small measure and measuring our successes in a small way, but we just have to figure out a way. And I know that our commissioner is dedicated to that, but that is a separate, I think it's a separate bucket, but I think we need to talk about it a little bit.
We're going to go to Q&A just after one last question, so be thinking if you have any questions for our panelists. But wanted to ask Clay real quick, what sort of policies, funding, et cetera, would you like to see from the federal government that you're not getting right now?
Well, so I think the federal government has the same opportunity that we in Maryland have recognized, and that's to embrace the national response framework. And again, that's the framework we use during crisis, and that's to centralize the effort. So in Maryland, what we do is we actually take all of our spending and we tie it to a spend plan that's tied to our coordination plan. Those are our 4 overarching goals and our objectives, and we make sure that we're addressing our objectives to support our communities out there. So I think what we would like to see is the federal government do the same thing. So rather than distribute funding amongst various federal agencies and then leave it up to states to figure out how to access that centralization would be very important, not only for the spending of dollars to make sure resources get in the right place, but also to make sure that there's coordination between actions. So if the law enforcement community is going after pill mills, it's really important that there's coordination there to ensure that the public health network is there to pick up individuals that might be impacted by an action. So I think what I'm saying is that the federal government has an opportunity to centralize their efforts more than they are using that national response framework.
Mm-hmm. I'd like to open it up to questions right there in the, over there.
Hi, my name is Janine Lovett, and I'm the director of the Chris Atwood Foundation, which is a nonprofit that my family started in memory of my little brother, Chris, who passed away from a heroin overdose in 2013. Actually, a month before he died, he was taken into the hospital and was revived from an overdose. And my family and I, we were there with him. We were all surrounding him and supporting him. And we walked out of that hospital with nothing. And my brother walked out with nothing as well. And I wanted to talk about a term called treat 'em and street 'em The Surgeon General just talked about this recently as well, and he said if somebody is being revived from an overdose and then released from the hospital with nothing, and then they come back a day or a week or a month later with another overdose, that's not an individual failing, that's a system failing.
Absolutely.
And, you know, we talk a lot about the importance of access to naloxone. If I had been given naloxone because I lived with my brother the month before he died, then I would have had it the day that I came home and found Christopher overdosed. But the hospital didn't give it to me. And I can't imagine, if he had been there for anaphylactic shock, I can't imagine them not making sure that we had an EpiPen, right? So, you know, we talk about addiction as a disease, but the medical community, it still isn't treating it like one, particularly the emergency department. So I guess my question is, you guys on the panel, you know, what do you see as a broad sweeping policy or way to address this, not just as an individual hospital by hospital basis, because that would take too long and we just don't have that time?
So I will tell you, in Maryland, one of the main focuses we have on what are known as non-fatal overdoses that report to our emergency department. So just in Maryland, we had 18,000 of them last year. And so we average about 50 a day in the state of Maryland in 49 different emergency departments. We recognize that those individuals have a higher propensity to re-overdose and likely die. So we're rolling out a program statewide that allows us to intervene and do an assessment and make sure that those patients, when they're discharged, they're hooked up with a peer recovery coach that can begin a journey with them, so that if they're not ready at that moment, that when they're ready, they can get them into treatment, that they're discharged with the life-saving drug naloxone, and that they're possibly discharged with their first dose of medication-assisted treatment and with a warm handoff to treatment. We've rolled that out into 15 hospitals in Maryland, and we're going to roll it out into all the hospitals in Maryland. Again, that's a resource need that we have, but you're absolutely right. We have to get into our emergency departments, because that's where we're seeing the highest risk for re-overdose and death. So that's what we're doing in Maryland, and that's being replicated in other states as well.
So I'll just add two things. One, if you live in Virginia or anywhere else for that matter, find the Chris Atwood Foundation, because they are giving free naloxone training, and I think free naloxone to a lot of people. They're doing a fantastic job. So, you know, a shout out to you. And I couldn't agree more with Clay. We call it warm handoff also. You can't give somebody Vivitrol right away if they've just gone an overdose. They have to be, clean for a couple of weeks, but you can give them Suboxone. And we believe very strongly that it's a lot cheaper to hand somebody that first batch of Suboxone pills than it is to bring them back into a very expensive emergency room situation or worse. So warm handoff is something that needs to get into the lexicon across country.
And so the debate over naloxone is often, and we also often hear the debate about naloxone. Naloxone is a life-saving drug. And so the law of unintended consequences, in Maryland, the health department has issued a standing order. You can go to any pharmacy and you get naloxone, and your insurance copay would be in place, but you can get this Narcan or naloxone to save lives. The challenge is that that's become an enabler as well, and you can have that discussion. But at the end of the day, we have to save a life in order to have the opportunity, down the road when that person's ready to ask for a treatment, to have that opportunity.
Well, we're about out of time. Thank you so much, everyone, for being here, and to our panelists as well.